by the way. And we should have that fixed now. Okay, so once we get that fixed, somebody wants to know what I think of ivermectin. I've not seen any studies on ivermectin for COVID-19, but it sure is good as an anti-parasitic agent. Okay, yes, we are aware of the echo, and I believe we have corrected it at this point, have we not? Because I can see what was causing it. So that should be fixed by now. We can have other questions, but thank you, Connie, nonetheless. And we also have a question from Suki, who also is a fairly new member of the channel, about 20 days along here. Suki says, hi, docs. Do you know what the percentage of deaths that are from all the positive tests? They make it sound so horrid, but only report positive tests, which in reality, most people do okay. That is correct. Most people do okay. Although, if there was a road that you drove on that 1 in 100 people died who drove on it, you probably would be awestruck by the number of people in your community who died from driving on that road. 1 in 100 is incredible. So even though 99% of people live, and of course people say we should focus on that, absolutely we should focus on that, but not at the expense of ignoring that 1 in 100 who's dying. Actually, it's more like 1.5. Of course, the number is a little bit up, a little bit down, depending on when you look at it. For example, early on, when not that many people were being tested, it looked like it may have been as high as 4%, but also that was a time that treatment was not as advanced as it is now, with 11 months of experience learning how to treat this. And also a little bit of a question if this current mutation that's more predominant in the world may be a little less deadly, and on the other hand, more contagious. We'll put it that way. Though hanging out more in the upper respiratory tract, less in the lower parts of the respiratory tract where it seems to cause more injury. That's just my own little speculation there. I haven't seen anything coming out from the scientific journals to necessarily support that. But absolutely, learning how to treat it has helped. And of course, having much more testing available to test people who aren't symptomatic, we find out that it's lower. And so that's how we get a mortality rate down to 1.5%. But again, look at your Facebook. How many friends do you have? Do you want 1.5 of every, or I guess it would be 1 of every 150 of those people to die? It is a serious thing, unlike most infectious disease that we deal with on a large scale these days. Certainly at least 10 times more deadly than influenza, for example. All right, other questions or comments from you, our viewers. Let's jump in here. Okay, so now that we got the sound fixed, thank you for helping me with that. We have a lot of people telling us that the sound is fixed, of course. And Deborah says it's better also. Lisa Ross, reading that certain antidepressant meds that have fluvoxamine helps keep COVID-19 patients from going to the hospital. There was a study published in JAMA in the last 2 weeks on fluvoxamine, or Luvox is the brand name for it. You say antidepressants containing, well, it's not that their antidepressants have other ingredients. It's just that's what the ingredient is. It's fluvoxamine, and that's the generic name, Luvox being the brand name. It's in a class called serotonin reuptake inhibitors, or SRI, and it's very similar in its action to Prozac or Celexa or Lexapro. Generic names would be fluoxetine, escitalopram, citalopram, also sertraline, Zoloft, and Paxil or paroxetine. These are all in the same class that work on specifically blocking serotonin's effects, and or increasing serotonin's effects. It's a reuptake inhibitor. The fluvoxamine may be a little different in its action. It's not officially called a reuptake inhibitor, but rather that's what it does because of what it is. It has the same effect. It does seem, in one study that was done, seem to keep people from getting hospitalized or getting severely ill with COVID-19 when given in um, a particular dosing schedule where you give a certain dose for a few days and then increase it and give it for a few days and then go up to the full dose for the rest of the 2-week period. Certainly it makes sense if somebody's dealing with depression right now. That would be a medicine we would want to choose to start them on. We haven't been using it for people who are COVID positive but without symptoms at this point. Somebody who's especially vulnerable, it would be a consideration, and I would talk it over with the patient. But with just the one study having been done and no confirmatory studies from other parties, we're not really quick to start doing it. We've seen a lot of things suggested with some suggestive data from small studies. And then when we get the larger studies, we find out that it's either absolutely not helpful or that it's actually harmful. This was what we found with the hydroxychloroquine in hospitalized patients, for example, although, again, I still feel like we could see some more data on that in the outpatient setting or even for asymptomatic cases. There's very specific areas where patients respond to things better than other. Another example would be what was it? I'm blocking on what it was that was found to. Oh, it was the steroid Depomedrol that the president got when he was hospitalized, found to definitely be helpful in people who needed respiratory support. Either being given supplemental oxygen or being ventilated or on a ventilator. Whereas people who weren't in the ICU and needing that kind of care that were given that medicine actually did worse with the medicine rather than better. So the right setting is the right place for certain medicines to help you and not harm you. Let's go back to other questions that you have. These are good questions. Thank you. Okay, that was the question from Lisa Ross. Thank you, Lisa. YouTube viewer says PCR tests, and I don't know what your question is about PCR tests. PCR tests are the ones that go in the nose and are checking for RNA and sometimes take a few days to get the result back, but they seem to be the best test as far as sensitivity and specificity right now. And then, of course, other tests that we're using. The thumbnail for today's show is another type of test called an antigen test that is not as sensitive as the PCR test. But a lot of people are under the impression that that is a good thing in that it's not giving you positives for people who probably aren't a danger to others, nor likely to be hospitalized themselves. So missing just that really, really low level probably is okay, especially when we don't want to over detect a disease in people who aren't going to be a threat anymore to other people. You don't want to quarantine somebody for 14 days because they have a little bit of mRNA left in their nose from when they just got over the infection and didn't even know it. That would be harmful rather than helpful. So not super sensitive seems to be a good thing if we back up the negative tests by having them do the PCR test that then comes back a few days later, so that you do still find out. At one point, my opinion was, what good is a test you have to repeat, especially when you have to repeat most of them? I think very differently about that today, given how many positive. We've had 2 positives just in our little office alone with the antigen test today. That's 2 people who you're sending home knowing they're infected, not kind of halfway quarantining because, it's just going to be a few days and the test comes back. No, you are positive now. Go home and quarantine. When it is the most crucial to get the patient away from other people. To wait days until the test comes back and find out, oh, wow, I really was positive. Well, now you're past the point when they were the most contagious early on in the course of the illness. So that's what I have to say about testing. So we've been very happy having the antigen tests here, especially when we're just being hit the hardest we've been hit so far in the whole pandemic here this week. To see 2 positive tests in a single day with the antigen test. And of course, the negatives that we've had today, we're sending off to do the PCR test to back up those negatives to just in case it was a false negative. Let's see. VM says, how do we know the real numbers when there are a lot of false positives? Um, I, I'm sorry, the tests I'm familiar with don't have a lot of false positives. There may be tests like that. I know there were some that had horrible results that unfortunately I believe the CDC was recommending they be used. Uh, we never had that in our area that I know of. The test that we use, the PCR test, and then the antigen test, uh, do not have. They're not known for a lot of false. Very, very, very small. As good as you're going to get for tests that are available. Okay, let's see. Where let's see what else we have here. Oh, hello to Teresa. Teresa, welcome. YouTube viewer. That's what causes the false positives and increase in cases. That's what, I'm sorry, I don't know what that means. Teresa is saying hi, and Suki. Oh no, I don't want people to die. It's just, I feel like the government is using it to scare the public. Um, the government. Given that voices in the government have been unusually actually talking down the severity of the pandemic, I would disagree with that. As far as those giving accurate information, their purpose is not to scare, but to have people be responsible and safe and do simple things to protect themselves and others that are no more inconvenient than just simply wearing a mask, which I'm doing today because we will have somebody else who is not a member of my household in the studio shortly, we hope, if Dr. Green comes. That's what caused, where were we left off? And Rusty has been here. Okay, Rusty, thank you. And YouTube viewer, if it is so infectious up to 6 feet away, why do they need to go so far up in the nose to detect it? Why do they go? Well, we did originally do that to catch people if they were positive at all. This was early on. You'd want to do and I don't like the term up the nose because there are people who are unfortunately in places of medicine where they can actually hurt people who have this concept of when you do something in the nose, you go up. That is absolutely incorrect. When you're putting an NG tube in or when you're doing a nasopharyngeal swab, the nasopharynx is straight back. You have to actually lift up the front of the nose to be able to get a view straight back into it. If you're just looking in without touching a nose, you're not going to be able to see straight back because the path of air through the nose goes, actually, does this show? We might be able to show it here. Let's have some fun with Francis. Francis, you don't mind this, do you? Oh, I thought half the head came off. Let's see. Okay. And then split it in half. Does it split in half? Oh, I'm sorry. I can't demonstrate. So anyway, you have to go in, and to get back to the pharynx, immediately go back. It's not up into the brain, it's up and back to the throat. That's what we're trying to get to. So originally, we wanted to be sure, the test was very, very sensitive to catch it at all. And part of the reason is if a person is going to be contagious and they don't yet have a lot, you want to catch it early on. Now we're not looking at it that way so much because we're concerned about catching cases before or when they're actually at the end of their contagious time. And it's a fine thing. There's a lot of discussion about it, about how much virus you want to pick up. And that's why we've gone to the antigen test here. And it is true that we're going to be having people that are positive after they do the antigen test, and it was negative. We're not even doing the antigen test on people who don't have symptoms in our office, having them go straight to the PCR test. So it's all in an effort to try to make the test as accurate as possible. All right, next. Where is it? Going back to your comments and questions. Okay. Lisa Russ, do you believe the vaccine is going to work? That's a good question. I believe that in 90 to 95% of individuals, if the data is correct that we've been told from the companies, which is what is going to be reviewed at the VRPAC meeting on December 10th, if they find that their interpretation of the data from the studies also supports that it is, 95% effective at preventing somebody from getting COVID-19, or like Moderna's product, 100% effective at keeping people from getting hospitalized or severe disease, then yes, I believe that for individuals, we will see it play out in those numbers, because this is being done with, each one of them alone is doing at least 30,000 participants. I believe Pfizer's study is, by the time it's all said and done, have 60,000 participants in their phase 3 trials. So yeah, chances are that's the percentage we're going to get as far as effectiveness in actual patients. Now, as far as the whole population or a whole country or the whole world, that's a different story, because that would only be the case if everyone was getting it. It looks like we need to get somewhere in the neighborhood. I'm going to be very, very general with this. I'm going to say 70%, but that's not an exact. It could be 10, 20 points either way of how much of the population needs to get immune for us to get to a place where it's not a threat anymore. And, that's going to depend on, two things. One, how many people get immunity from having the disease, and how many people get immunity from the vaccine. The other question is, how long is the vaccine good? Well, it looks like it's certainly good for about a year's time, if not even longer. If it is short, like a year, having it integrated into a combined flu and coronavirus shot, because you get your flu shot every year anyway, looks like it would be a way to keep us protected without having coronavirus be an ongoing big threat like it is now. So it really would be good if enough people participated in the vaccine, which a lot of people think once it gets going and they see that people are getting it and that numbers are going down because of it, that people will be more likely to participate. Of course, you have the other extreme of when the numbers really go down, then people won't feel as much need to get to it. So we may have trouble finishing it off there at the end, getting enough people to keep getting the vaccine. That's one of the reasons that there would be encouragement to do it quickly. Of course, it's limited in just, the logistics of manufacturing it and getting it out to people. And thankfully, we have more than one. We have the two that are already asking for authorization, the one by Pfizer and BioNTech, and then the one by Moderna, which seems to really be good. Then there's also one by AstraZeneca that doesn't require all the special refrigeration requirements. It actually has this, which one was it? Was it the AstraZeneca one that had the funny feature of, it looks like you want to give a half dose for the first dose and then the full dose for the second dose to get the better protection. At least initially, that's what the numbers look like. All right, moving on to more of your comments and questions. Thank you. This is great. Even without Dr. Gwain showing up in the, he is actually doing real medicine. So he's not just relaxing. All right. PCR test designed by, I don't know who that is. What is an antigen test? We covered that. Is it less invasive? The antigen test, you still want to get a definite sample. You don't want to miss the virus, so you do want to go into the nose, but you don't have to go all the way back to the nasopharynx necessarily, like with the early PCR instructions that we had. That's down the throat. What's down the throat? What's down the throat? So we're talking about the nasopharynx, different from the oropharynx, which is generally what we'd call the throat, or I guess you could call it the nose throat. Well, you could, nobody else does, but nasopharynx is the upper part of the throat, and that's because the virus hangs out to be found. Strep tests, we do it in the throat because that's where the bacteria for strep is likely to be, and we'll do that on patients who have a sore throat with the fever. So it's possible for a patient to get swabbed 4 times in a single visit if they have a sore throat, a fever, and their initial COVID test is negative, so that we have to back it up with the PCR test. And thankfully today, the patients have been getting just the influenza, which so far all of our influenza tests has been negative. Influenza has not really hit yet by what we're measuring here in our office, but Boy, COVID, it's here in our area right now. We are certainly seeing it in patients. And again, we're only testing in our office because of limited supplies, people with symptoms. So other people with symptoms, we're getting very high test positivity rate right now. In the past, it hasn't been. We've had lots of negatives. The occasional positive comes through, maybe one a week. But now this week, it looks like it's really something. Okay, other comments and questions? When I put in my code correctly to get into. That's down the throat. VM, how do you treat your new COVID patients? We, being an outpatient facility, we don't give a specific treatment because there is not anything that's FDA approved for the lightly symptomatic, not hospitalized patient that's really found to make a difference in except for the fluvoxamine. That study does look very promising. And the reason we haven't started using it is because it's just been that one initial study. It hasn't even, other than coming up in that, what's it called? JAMA network, it hasn't been published beyond that. So we're waiting to see confirmation for that. If somebody was already going to take that medicine or were already on it, then absolutely that would be something that we would look into a little more, have a conversation about it. But to put somebody on a medicine that's only been found in a single study that's been published just on an online source of JAMA and not anything beyond that, with the numbers that they had, it's just not enough for us to subject patients to potential risks of that. All right, the other comments here. Let's see. If I can put in my number correctly, we'll get to your comments and questions. Okay, Suki asks, if a pregnant woman gets COVID, could the baby be born with an immunity to it? I do not know, but I do know that pregnant women are especially vulnerable to COVID-19 as far as bad outcomes and higher incidence of hospitalizations and needing more critical care. So it's a group that we really want to protect and really have them act kind of like we're encouraging people who are elderly and have a number of health problems to be especially isolating themselves right now as the numbers are really going up. DW says, my husband and I just recovered from COVID. We had totally different symptoms. We see that. Married couples, totally different symptoms. He had the migraine-like headaches. I had just about every symptom. We are in the Chicago area. We have that too. We have people talking about, the husband will have loss of taste and smell. The wife will have fever and fatigue and maybe even swollen lymph nodes, just different patterns. Okay, so thank you so much for coming to our show today. And those of you who aren't already members, go ahead. If you don't have to be a member, though, to get notifications. You just have to make sure that bell icon is clicked when you hit the subscribe button. Dr. Gwain, if he was here, would want to let you know about drgreenknight.com, his daily blog. Today is about Advent and how that relates to our view of the world and making it a more positive and peace-pursuing type of activity. He would also say thank you to Teresa Roa and Boo Boo Kitty. And I would like to say thank you to Boo Boo Kitty and also to Lindsay Antwine for being a part of making this happen because they are on Patreon. Patreon, you can find Dr. Green Knight there. You can also find Dr. Vaughn. That's what I call myself on Patreon. Until next time, Dr. Mark Vaughn telling you to stay in good health.